Let me start with this osteoporosis, important topic. Okay, by low bone mass and architecture deterioration of the bone tissue with consequent increase in the bone fragility. Since I'm very tired, my mouth and is not coordinating. I'm very sorry for that. Okay, risk factor for the osteoporosis include the following. That's remember, take a pen, write it down. Take an iPad, write it down. Memorize it. Very, very important, my dear friends. Okay, let me start with this. Advanced age, more than 50 years. Female sex, white or Asian ethnicity. So you know my ethnicity, right? Okay. Genetic factors such as family history of osteoporosis, thin built or small stature. Example, body weight less than 127 lb, that pounds. Amenorrhea, late menarche, early menopause, postmenopausal state, physical inactivity or immobilization, use of drugs, anticonvulsants, systemic steroids, thyroid supplements, heparin, chemotherapeutic agents, insulin. These are very important drugs you need to remember. So you need to memorize for that, and you just write it down, my dear friends. Otherwise, you keep playing my video, and definitely it will help you, because I keep revising the drugs so that it will keep you in your mind for permanent. Okay, alcohol and tobacco use, very important questions will be asked on alcohol and tobacco use. Androgen and estrogen deficiency, calcium deficiency, and Dovegas hump. No need to worry about that hump. Okay, there is a mnemonic for this. You can remember this on the screen. I don't want to tell again and again. Just you can write it down if you want. Okay, just let me pause for 5 seconds so that just pause it and write it down, and definitely it will help you. Okay, it's like an osteoporosis only. Okay, potentially modified risk factors, very important, includes cigarette smoking, low body weight, estrogen deficiency such as that caused by early menopause less than 45 years, or a bilateral ovariectomy, or prolonged premenopausal amenorrhea more than 1 year, low lifelong calcium intake, alcoholism, impaired eyesight despite adequate correction, recurrent falls, inadequate physical activity, and a poor health and frailty. History of loss of height, low body weight, signs that might indicate existing osteoporosis like kyphosis, Dovegas hump, point tenderness, or vertebra, or other suspected fracture site. Signs suggestive of secondary osteoporosis, signs in the older patient that may indicate increase of fall risk. Okay, the American College of Physicians (ACP) has similar recommendations for the screening of osteoporosis in men, including the periodic evaluation of the risk factors in older men before age 65 years, particularly men who do not choose to be screened, and obtaining a dual X-ray absorptiometry (DXA), very, very important. This you need to remember for men at increased risk for the disease who are candidates for a drug therapy. The USPSTF, has issued update recommendations on screening of osteoporosis. What are the recommendations? The woman aged 65 years and older without previous known fractures are a secondary cause of osteoporosis. So you need to screen for this. BMD is nothing but bone mineral density. So you have to do in the following patients: woman younger than 65 years whose 10 years fracture risk is equal to or greater than that of a 65-year-old white woman without additional risk factors. The risk factor for osteoporosis in a man include the following. Which are the risk factors that include? More than 70 years, low body weight, greater than 10% of weight loss, physical inactivity, corticosteroid use, androgen depression therapy, previous fragility fracture. So among these, what is the most important? That's the age. Remember, complete blood count results may reveal anemia, as in sickle cell disease. Patients with anemia, particularly those with older than 60 years, should also be evaluated for multiple myeloma and may raise the suspicion of alcohol abuse. Okay, this is what the laboratory findings I'm talking about right now. Serum markers for the bone formation, very important, include the following. Remember about these bone markers, very important. Okay, osteoblast products. Currently available urinary markers for bone resorptions include the following: hydroxyproline free and total peridonulins, all this blah 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 blah, you can write it down and you have to memorize that. This is very important for USMLE examination, my dear friends. Currently, this is very important. I'm going to talk about the currently available serum markers for the bone resorption include cross-linked C teropeptide of a type 1 collagen ICTP and a tartrate resistant acid phosphatase, as well as NTX-CTX. What is NTX-CTX? You can go back my one slide back. You can find it what is NTX and CTX. Of all the biochemical markers bone turnover mentioned above, the one most commonly used in clinical practice are BSAPOC, urinary NTX, and serum CTX. I don't know how do you remember these things. You have to, that's it. I don't know. To tell you frankly, guys, I'm very sorry for that. Okay, the patients with the hyperparathyroidism, Paget's disease, or stimulation can have elevation of BSP. So sometimes in a patient, elevation of BSAP can be seen in these patients also. So remember this also. This is very important point. Okay, plain radiography may be indicated if fracture is already suspected or if the patient have lost more than 1.5 inch of height. Osteopenia is suggested by cortical width that is less than a medullary width. DXA is currently criterion standard for evaluation of BMD. BMD is nothing but a bone mineral density. Bone mineral density. Well, we have a CT scan also. CT scan is superior than this, but this is very superior than a CT scan because low cost, easily available, and you can do on a outpatient department also. Single photon absorptiometry SPA of the proximal forearm provides a precision and offers low radiation exposure, but it is relatively insensitive for detecting early stage osteoporosis because it measures cortical rather than a trabecular bone. Dual photon absorptiometry DPA can measure bone BMD, bone mineral density in the spine and the proximal floor, but its use is limited by poor reproducibility and prolonged scanning times and artifacts caused by vascular calcifications. You need to remember the artifacts, limitations, and everything. QCT, there is a continuous CT scanning of the spine, is the most sensitive method of diagnosing osteoporosis because it measures a trabecular bone within the vertebral body. Okay, the MRI can be used to discriminate between the acute and the chronic fracture of vertebra and occult stress fracture of the proximal. Sometimes they can ask you which of the following investigation you want to do to differentiate whether it's a chronic or acute. So remember about the MRI. Bone scanning assesses the functionality and tissue metabolism of the organs by using radionuclide that emits a radiation in the proportion to its attachment to a target structure. This technique detects an increase in the osteoblastic activity. Okay, the bisphosphonates, what do you want to treat, how do you want to treat, that's very important. Bisphosphonates, SERM, relaxin, calcitonin, blah 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 blah. All therapies should be given with the calcium and the vitamin D supplementation. So the important thing, basic thing is calcium and the vitamin D, and depending on that you can give the other drugs also. Okay, there is a recommendation for that. The NOF, National Osteoporosis Foundation, recommendation that pharmacology therapy should be reserved for postmenopausal women and men aged 50 years and older who present with the following: a hip or a vertebral fracture, T-score of, this is very important. T-score is very important, guys. By the T-score you need to differentiate whether many diseases. I think I will post a video on that, on a T-score only, not on a 99 score. I'm going to post video on a T-score. Okay, T-score of less than 2 minus 2.5 or less at a femoral neck or a spine after appropriate evaluation to exclude the secondary cause, low bone mass. Okay, first line agent, second line agent, last line agent. First line agent: alendronate, residronate, zoledronic acid, denosumab. Okay, second line agent is ibandronate. Third or second line is raloxifene. Last line agent is the calcitonin. Remember, last line is the calcitonin. That's very important. You need to know. Treatment of patients with a very high fracture risk in home bisphosphonate therapy has failed. You can use teriparatide. Okay. This is very important for USMLE step 3. You need to remember the dose and the age, because sometimes they can ask you, the patient of 18 years old, what is the daily requirement, calcium requirement for the patients with 19 years old or 18 years old or 17 years old. So you need to memorize this. This is very important. This is a daily calcium intake for patients with following ages. Okay, what are the other things what else you can do other than pharmacotherapy is the physical therapy. Aerobic low impact exercises such as walking, bicycling generally are recommended. Primary prevention of osteoporosis starts in childhood. Patients will require adequate calcium intake, vitamin D intake, weight bearing exercises. Beyond this, prevention of osteoporosis has two components: behavioral modification and pharmacological interventions. Again, NOF, I think NOF won't leave you. Anyway, they have this modified to behavior should be modified to reduce the risk of developing osteoporosis. Cigarette smoking, if you're smoking right now, stop smoking, guys. This is not good for your health, not for my health too. Okay, cigarette smoking, physical inactivity, intake of alcohol, caffeine, sodium, animal protein, and calcium. Patients should be counseled on smoking cessation and moderate alcohol intake. Patients who have disorders or take medication that can cause or accelerate bone loss should receive calcium and vitamin D supplementation, and in some cases pharmacological treatment. So among this, very important is cigarette smoking than alcohol consumption. Remember, very important. They can ask you which of the following is the most important risk factor for that. If they give smoking and alcohol, if you have to choose between this and the smoking, choose the smoking. That's very important. Tobacco. Pharmacological prevention methods includes calcium supplementation, administration of relaxafen, bisphosphonates. Relaxafen and bisphosphonates should be considered as a first-line agent for prevention of osteoporosis. Oh my god, I'm not gonna end today. I think this is going to be my longest video since I posted my 100 video. Okay, estrogen progesterone therapy is no longer considered as a first-line approach for a treatment for osteoporosis in a postmenopausal woman because it is associated with increased risk for breast cancer, stroke, venous thromboembolism, and perhaps coronary diseases. Estrogen is now only recommended if patients are also seeking a relief of postmenopausal symptoms. Bone density checks are recommended every 2 years in postmenopausal women. This is for a screening after the treatment. How do you prognosis, follow up. Okay. DXA should be repeated every 2 to 3 years if the baseline test results are normal. DXA should be performed every 1 to 2 years in a patients who are undergoing osteoporosis treatment. Very, very, very important. Write it down. Okay, with this I am done with my video. Thank you so much for watching my video. Thank you so much. If you have any questions, if I made any mistakes, please apologize. I apologize for that, and please do subscribe to my channels. And if you find any mistakes, please do let me know so that I can correct. Thank you so much for watching my video. Take care.